Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of patient care through dynamic insights, practical clinic tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in ophthalmology and optometry. Our mission is clear: empower eye care providers with the knowledge and tools needed to deliver exceptional patient care. The Advanced Patient Care podcast is dedicated to elevating our craft, one episode at a time.
Hey everybody, thanks for tuning in. I'm Mike Greenwood, a surgeon up at Vance Thompson Vision in West Fargo, North Dakota. I've got some special guests with me today, and today we are going to talk about ICLs and refractive lens exchange, or RLE. And how about John? Why don't you go ahead and introduce yourself?
Yes, I'm John Gertz. I'm in the Omaha office, optometrist here.
And Kristen?
And I'm Kristen Moore. I'm one of the optometrists at our Sioux Falls location.
Excellent. Well, thank you guys for taking time out of your day to talk a little bit about eye care and vision care with us and some of the doctors that are listening to this. So, a lot of people know about LASIK, and whether you're having refractive surgery or, whatever it may be, to maybe be a little bit more independent from glasses, people always say the term LASIK. So even if they're not having LASIK, they'll be like, yeah, I'm going to go get LASIK, because everybody knows what that means. But there's different tools in our toolbox that we can use, whether it's LASIK, PRK, SMILE, and now ICLs and RLE. Let's talk a little bit about ICLs and RLE. So first of all, again, I mentioned it, but ICLs is short for implantable Collamer lens. Think of it like a contact lens that goes inside the eye, and refractive lens exchange is RLE. And we'll talk about that, but basically it's replacing the clear lens of somebody with an artificial lens to give them, spectacle independence. So, Kristen, I'll start with you. When someone's in the office, you're talking to them about all the different options. But what are you looking for on an exam with patients when they're coming in for a refractive, visit?
Yeah, so the big things that we're touching on when a patient comes in: age and demographic. So how old are they? Looking at the prescription, glasses, contacts. Are they a myope? Are they a hyperope? Any astigmatism? You want to look at some lifestyle factors. So what is their job? Are they looking for independence for near and far if they're in that presbyope age, or are they a young, healthy 30-year-old that is just sick of putting their contacts in? And so you're kind of looking at their individual goals for independence too. In the topic specific to ICL, a lot of patients, like you said, come in and LASIK is just a catch-all term used. They just say, hey, I'm just curious about LASIK, and they have no idea maybe what LASIK even is. So you're looking at a lot of scans on their cornea to make sure, if they are not a LASIK candidate, what other options we can provide for patients. And oftentimes that's when we go into the ICL, the implantable Collamer lens for our higher myopes, or for a refractive lens exchange if we have patients in the presbyopic era you could think of that want independence from up close and far away.
Yeah. And John, I'll have you kind of dive another layer deeper on maybe some of the things Kristen mentioned. So, she mentioned corneas or refractive error and things like that. So what would maybe push somebody where LASIK maybe isn't their best option, but ICL is their best option?
Yeah, and so I think one thing is choosing what's best for them today, but it's also looking at what's best for them long term. And so in 5, 10, 15, 20 years, what's going to be the best technology for their vision long term. As far as when I kind of started this, we did LASIK in about everybody. And then the ICLs came out, and the ICLs were for those patients that had too high a correction for LASIK. But now we're starting to do ICLs down, in patients that in the past we would have even done PRK on. We can go down to -3.5 or so. the big thing there is preserving the cornea. It's reversible. And so we keep the cornea pristine, which is good for them in the long term when they end up having cataract surgery. Because we alter, and we're getting a little ahead of ourselves here, but because we alter the cornea with LASIK, we negate some of the ability to put some of the advanced implants in those patients. Where with ICL, it's very simple. We remove the lens. Now they're back to a virgin eye, remove their cornea, and they have the full array of lens options available.
Yeah. So great point. So some of the FDA indications, which are guidelines for us, but not necessarily hard yeses or nos. So like you mentioned, the ICL is reversible. So if you put it in someone and for some reason they don't want it, or it doesn't fit their eye, or whatever it may be, which is extremely rare, you can take it out and you haven't altered the shape of the cornea. When you alter the shape of the cornea, it bends, light a little bit different and maybe can um, lead to some maybe glare, halo type stuff. Maybe not so much now right after LASIK, but down the road when you want to pair that with an advanced implant that keeps them independent from glasses, after their cataract surgery. So that's a really, really great point. The ICL, it's indicated for -3 to a -15, can go all the way up to -20 if you pair that with, laser touch up with LASIK or PRK. It also corrects for astigmatism up to 4 diopters of astigmatism. Again, you could do a touch up on that. Currently in the US, not available for hyperopia correction or anything less than a -3, but works extremely well. And I was one of those people, back in the day. I have ICLs. I've got the previous version where we didn't have astigmatism correction and we had to do peripheral iridotomies. But now with the updated versions of it, we can correct astigmatism and it's a lot safer, without having to do the PIs. And so I guess on the pre-op side of things, we're looking at maybe patients who have a thinner cornea where LASIK isn't going to be the top option. We don't have to alter the shape of the cornea, so ICL fits in nicely there. Maybe like you said, they're a higher refractive error, but they don't have to be super high. We're not looking at people that are like -10 plus. It goes all the way down to -3, as John mentioned, and so we've used it in those situations. So, and I guess there is some age things on the FDA, but it's basically 18 to 45, which leads me to the next part. Now, say we've got this same patient. But John, you mentioned people come in and we would do LASIK on everything, including people, age 45, 55, maybe even 65, because they didn't have cataract, but they wanted to be independent from glasses. And we're like, all right, well, we'll do LASIK. But what's the problem if we do LASIK in someone who's 50 years old and they're wearing a bifocal?
Yeah, and in the past, obviously you push them into reading glasses. In the past, we did a lot of monovision in these patients, and so which works great. Patients, as long as their expectations are in line, monovision is a good option. But I don't think it's as good an option as the new multifocal IOLs. And so, somebody that, again, the ICL is approved to 45 kind of for a reason, and I think that reason is presbyopia. After this period of time, we can, we give them much more in the ability to get them out of glasses if we move to a multifocal IOL in a refractive lens exchange.
Yeah. Kristen, what age do you have an age that you start talking RLE, or is it more symptoms, meaning like they're in readers, or what guides you in that way versus an ICL or cornea-based surgery?
Yeah, I think it gets really tricky in the mid-40s, especially if someone isn't presbyopic yet. But I typically say mid to late 40s is when you're entering the era of a refractive lens exchange. And it also depends, is the patient a very high myope? Have they had a PVD yet? Those are two things that will push the needle for me. If, you have a 45-year-old coming who's a high myope or a moderate myope, who has not had a PVD, then that's kind of even a little bit of a harder conversation to have. So mid to late 40s is when they enter that refractive lens exchange era. And like you mentioned, the FDA approval for ICL, I believe, cuts off at 45. But not to say, you can do things off label too, as long as patient consents to that, and we're aware of that too.
Yeah.
And then once they're in the 50s, that's when I'm pretty much having the refractive lens exchange conversation. Almost everyone with age 50 has entered presbyopia to some extent, or they're holding off bifocals by, holding everything at an arm's length. So they know the bifocal's coming, even if, yes, even if they're denying it. And that's kind of mid to late 40s is when I enter that RLE range, and you're kind of leaving that LASIK ICL range softly.
Yeah. As the saying goes, Father Time is undefeated.
One other thing we always consider, is the hyperopes. And the hyperopic corrections are not available in the United States with ICLs, but we can do any amount of hyperopia with the refractive lens exchange. One thing we look at for all these procedures is anterior chamber depth. We need a certain anterior chamber depth, FDA's 3 millimeters for an ICL, which is one of the reasons I think that hyperopia has not been approved. So many hyperopes have shallow chambers. But we now take that hyperopic patient that's in their 50s. They've obviously become presbyopic a little earlier, and so they understand that. But they also, as the lens matures, are obviously getting a little more shallow anterior chamber. And so by doing their lens exchange, we take care of that issue for them as well. And so I'm much more apt to move those hyperopes, even in their 40s, into lens exchange, where I agree the high myopes have the higher risk of retinal detachment. So, kind of holding off on them.
Yeah. And Kristen, you touched on this. Not having a PVD is greater risk for potential retinal detachment following cataract or refractive lens exchange, correct?
Yes.
Yeah. And there's a calculator online that a lot of us use that kind of helps, quantify that risk for us. We'll pause for just 1 second here. All right. And ready, back on. And so it kind of sounds like age or the use of reading glasses, kind of like the trigger to start talking to people about RLE. John, you touched on, the patients, we're not so much worried about minus or plus with the refractive error, but RLE does have a wider range because we can handle, the hyperopes. And those are kind of, historically the slam dunks were a mild hyperope who needs reading glasses. RLE is like going to make them so happy. And but now that's broadened because the IOL technology has gotten so well that you can take these myopic patients or hyperopic patients, or some people that are even emmetropic but presbyopic. It works well for them. And it's the same thing we touched on with the ICLs. It used to be kind of the extreme myopes, but now it's just myopes that it fits into. And part of that is, one, the technology keeps getting better with the implants, whether it's the safety of the ICL or the better technology with the implants with the refractive lens exchange. I'll kind of real briefly take you through the two procedures, and then we'll get into post-op care. But the procedure for RLE, it's cataract surgery before they get a cataract, so nothing different there. On the ICL side, it's like putting in a lens at the end of cataract surgery. We just didn't remove the old lens. And so we make a couple small incisions. We use some viscoelastic to give us more room. We slide the lens in, and then we rinse out the viscoelastic, and we're done. And so the procedure itself is relatively straightforward, but obviously both of them are very delicate, and you want someone who does a lot of these to be comfortable with it. But one of the more challenging things with ICLs is getting the sizing right because they kind of come in a small, medium, large, extra large. If it's too small, it can, wiggle around a little bit. We don't like that. If it's too big, it can crowd the angle, make eye pressures go up. Obviously, we don't want that. But again, with the Evo, the flow through the ICL is much better. And now we've got a lot better ways to predict the size and the vault for these patients. And surprise, surprise, AI is playing a role in that of fine tuning it. So we've been using some tools with that. That's been really helpful. So now the patient has had surgery. So let's go back to the ICL. What are we looking for in kind of like the immediate post-op? So, maybe day of and 1 day, post-op with these ICLs. John, maybe I'll ask you first.
Yeah, so 1 day, vision should be relatively good. Sometimes they'll have a little edema of the cornea, and so that's allowed after surgery. Look at the incision, make sure it's sealed and looks good. Main thing we're looking for is the angle, and so with the ICL, if there's too much vault on the ICL, you can actually close the angle. And so again, with Evo's the new lens that has the fenestration in the center of the lens, so fluid can pass forward. So that's less of an issue, but you want to just make sure the anterior chamber is deep and quiet. And then obviously look for cell and flare. These patients are all receiving an intracameral injection of a steroid and antibiotic at the time of surgery. So, I mean, a lot of times I have to really look for any inflammation with an ICL. Vault wise, you want the ideal vault's 500 microns. The simple way to measure this is just look at the thickness of the cornea, and you want the vault of the ICL to be about the thickness of the cornea.
Yeah, and so you take kind of like a slit beam and kind of do a cross section of the cornea, and then just move a little more posterior, find where the ICL is, find where the natural crystalline lens is, and look at that difference and compare it to the thickness of the cornea, like you mentioned. And yeah, anywhere 500 is perfect, but you can go a little bit below that. I mean, we have some patients that we follow down to 100, again, with the Evo, because there's fluid that's flowing through there. They can go up to 1,000, on the vault, but when it gets into that higher one, you really want to watch the angle on that. So again, the sizing is the most important part. And John, one more question on the ICL, and then I'll go to Kristen for the RLE. But do you typically see patients do these a day apart, a week apart, or both eyes same day?
We typically do them both the same day, and they are treated as two different surgical cases. And so we go into the OR, do the first case, they exit the OR post-op, and then go in for the second eye. So totally different scrub, new instruments, everything. So risk of infection is the same as doing it 2 different days. And they're here. Many of these patients drive a long ways. They love having both eyes done the same day.
Yeah, totally agree. We do it the same way here, and I think at all of our sites. So very, again, similar to LASIK, bilateral, same day. Patients are really happy. So, Kristen, let's flip it over to you. Now we're talking refractive lens exchange, and I'll ask the last question first in your case, and then you can kind of get into what are you looking for in the post-op period. But are you patients having refractive lens exchange day apart, week apart, month apart, same day?
Yeah, also for refractive lens exchange, you're not billing insurance, so you don't have to follow that post-op needing the surgery posted on a different date. So you can do both eyes on the same day additionally. Some patients still opt for a day apart, but there are cases, and I think we're moving more towards it, where you can have both eyes done on the same day. A lot of it's dependent on how far the patient's traveling to. So similar to an ICL.
And then what are you looking for on, your post-op exam? Maybe, you can briefly go over like the 1 day, 1 week. I kind of, mentioned it's similar to cataract surgery on the procedure side. And then, maybe how far out do you watch these patients?
Yeah, so follow-up is going to be nearly identical to cataract surgery. So you're doing a 1 day post-op. Similar to ICL, you're checking the incisions, the main wounds, and paracentesis, making sure there's no leaks. Since they did remove the crystalline lens, you want to check for any lens fragments. Those typically settle inferior on the angle. So you're also checking for any sort of retained lens fragment. And as far as the cornea, normal to see corneal edema, normal to see a fair amount of SPK post-op day 1. Pressure can also spike, as with cataract surgery too. So if their pressure is spiking, you want to treat that either topically, or if that means burping the paracentesis to, let some of the aqueous out too. Follow-up, we also see them a week later. Again, that's more so for checking for endophthalmitis. Again, very rare, but typically that presents in the later days after surgery. And then again, we're checking them at the month, making sure the retinal health is intact too. So personally, I like to dilate my younger patients that have refractive lens exchanges and make sure, especially if they're a previous myope or a moderate myope, I like to make sure the retina is healthy, no induced holes or tears. Sometimes a PVD can be induced later on. And so as with cataract surgery, you're giving patients, letting them know if you're experiencing any new flashes of light or floaters. We also do see them 3 months down the road too. And essentially that's more so to check on how they're doing visually and adapting to, essentially a lot of them will have a multifocal lens. And so some of them are adapting to a different near point. A lot of them are presbyopes like we discussed, but finding the focal point for, near and intermediate is a bit of an adjustment. And so we follow up with them a couple of months later to check for any residual refractive error, to check for any PCO, and just to see how the patient's overall adapting to the lens.
Yeah. And I agree with you. Most of these patients are getting multifocals. Trifocal is the most recent one. But occasionally using the light adjustable lens and things like that, if that fits the patient a little bit better. John, anything to add on the RLE side of things?
Yeah, really, it's picking the technology that's right for that patient. Rarely do we do a standard lens. We have done it. But the LAL is a wonderful lens, and where we really enjoy that lens is post-refractive patients. And so, we talked about hyperopes. Well, short of the good Lord, the main producer of hyperopes was RK. And so we're seeing a lot of those patients come in, and they're coming in at that period of time, when they're presbyopic, they're a +3, they're really struggling. And so we use an LAL in those patients, even with a clear lens, and produce some monovision. They're really, really happy. So
Yeah, I agree. Guys, this has been awesome. I think we covered, who are great candidates on this, briefly what the surgery is, and then what are kind of the watch outs on the aftercare and what to look out for. Maybe give me, your summary, last thing you want people to remember. Kristen, I'll start with you because John just got talking, but what's your final takeaway that you want people to hang on to?
Yeah, final takeaway, those high myopes have options now, whereas, maybe they might have thought they weren't candidates, or, you might have patients who are high myopes and abusing contact lens wear. And so it's best for their health to maybe pursue options to get out of contacts. And we have options for those higher myopes, and they're also extremely happy after ICL. They're used to, having those super, super thick glasses or contact lenses, or maybe a toric that's just really tough to fit. So patient satisfaction I've been super impressed with ICLs.
Yeah. John?
Yeah, mine would be just multifocal technology has come a long, long way in the last 30 years. And I think we need to really start thinking about altering the cornea, especially when we have great options like ICL in the younger patients, and even those lower myopes, so that we don't take away their ability to enjoy the multifocal technology when they go through a lensectomy or go through cataract surgery.
Yeah.
We have a technician that works for us. He was a -5 LASIK patient. He's now 46 years old. Just had a clear lensectomy or refractive lensectomy, and we talked to him. We said, "You're a -5, LASIK patient. I do an LAL. And he said, nah, I've been watching these multifocal patients and I want a multifocal. So we did a multifocal in him, -5 LASIK. Remember, cornea's been altered, and he's doing absolutely fantastic. And so uh, the technology just keeps getting better and better. Patient satisfaction, the FDA study with a multifocal was 99.2%, saying they would get the lens again. And so with odds like that, I just see that we're going to go more and more to lens-based surgeries.
Yeah, I totally agree. You guys summed it up really well. I have 2 points because I forgot one earlier. But if you have an ICL, and then when you do need cataract surgery, when you're 65 or whenever, we just take out the ICL, we take out your cataract, new lens goes in to replace both of them. So you don't. That's how the ICL gets out. We don't have to re-put it back in. My final takeaway is echoing what you guys said. My happiest patients are ICL patients. And then now recently, my happiest patients have been RLE patients because now they're getting out of glasses for distance and up close, and they've been just as ecstatic or more compared to the ICL patients for all the reasons you guys mentioned. So, yeah, the technology is amazing. Patients are happy, and we want to make sure everybody gets into the end zone. So we'll wrap it up. Thank you guys so much for listening. John, Kristen, thank you guys for sharing your expertise on it, and look forward to catching up with you guys soon.
Thank you.
Thank you.
Thank you for tuning in to Advanced Patient Care, the exclusive podcast by Vance Thompson Vision. Want to learn more? Schedule a personalized mini fellowship at one of our clinics where you can gain hands-on experience and real-world applications tailored to your practice. For more resources and information, visit vancethompsonvision.com/OD. Let's continue advancing patient care together, one episode, one innovation, and one patient at a time.